honestly say like crossing separate workplaces. So Barbie just first you can go chat just not the things so nobody's was you get the other trying she is come. Do you know first I don't know this to please kind of other than just like you can say
Stories of it.
similarity and like it's all
I have no idea.
and you also I will
I have no idea.
download and it's on offline trying to talk take dots can simply show source owns an advantage shipment gives the key dot it functions and it says present in this graph and show you these are dot key dots will that work? Oh yeah. Stop it. I started in the gender. I can't show the bush. And about it, shut it through. And that is the shit that it get them. Males. So the credit in these pretty
I clipped it all.
Thank you. Trying to get fancy, fancy.
talkies. And it's about worse than
So now what will be the next time you wear a suit? Graduation? You wear graduation?
Oh.
Not a suit.
how long
No, I don't think I wear a suit for my white coat ceremony because I think it was
Right.
we'll see. No, it really comes out of respecting favorites. But these are Sierra colors.
You are not. You still need to be.
This is not a word of my interview.
But, well, I can understand. We want it up.
And it kind of matches my presentation. Anyway,
are you standard?
If you had to like a series out of like,
oh, I don't have anything.
anything on there,
It's just blue.
I'm just writing zeros.
But I'm like, puppets. How did it? Those double producing us. Well, I've stayed on the smash. Sexually best. All times. People from that. Me there's a big man. Big. Yeah, rich. It's as the option. I've been so much. I'll see. Stand on me. But for thinking about that. More views. Her. Date. If you want, it's all. It's not like that's all. You don't want everything. But you said they have nuts. It's like the tap. So, why you sit and come to us like that? It's how he doesn't start it. Then, yeah, we would have said, popped in. What was it? Yeah, kind of about not to bell. The more it's fun, so I was not like. So yeah, it was like model just being very embraced. Nothing because these kids are falling rich. The here's that they keep done. Finish it. Then and what buttons? It's probably sure I'm really actively. I'm shameless. A lot of message. That's silly. I mean, it's actually pretty simple. Like I'm shaking fact, and it's such a state. I'm I just get sit by it. So like just some criteria. I just like this block is because I've been 98%. I know it. It's a thing is stuff that first they use the high spot. Nice. So just really good. But perfect. So, wonderful gratitude.
So, good morning, everyone. I'm Brittany McConkie. I'm one of the professors here at SCU. And super excited that you're all here today. So, thank you so much for this time. We really appreciate your presence, your feedback. So, it's good. And I'm going to introduce our first speaker. And just as part of this bit, she's majoring in biology with a concentration in medical science. She's from South Africa and has been at SNU for 4 years. While at SNU, she was a part of the SNU women's golf team. After graduation, she plans to attend Ross University School of Medicine.
Thanks.
afternoon, everyone. Actually, I'm and today I'll be exploring one of the coolest intersections in science, neuroscience and unique athletic performance. Now, athletes are obsessed with training their bodies, but what if we've been ignoring the most important, powerful tool of all, our brain? During high-pressure situation, the brain is flooded with excitatory neurons. This is where GABA will step in to modulate their systems. So GABA does this by keeping movements sharp and precise and in focus as well. But here's the twist. We don't fully understand how training actually affects the brain. Does GABA adapt like muscle does? That is the gap I'm trying to explore. Because maybe it's not just muscle memory, but neural efficiency that breaks good from right. So for my hypotheses, I'll investigate how athletic training enhances GABA-based inhibition, improving performance under stress. Now, training sculpts the body, but what if it sculpts the neurochemistry as well, and we can actually measure it and enhance performance in athletes even better? So first of all, before we start, what is neurotransmitters? Neurotransmitters are chemical messengers that operate both travel through synapses. It's basically how these neurons communicate with one another. You get two types of neurotransmitters. You get excitatory neurotransmitters that are more associated with the go signals, intense activity. On the other hand, we have inhibitory neurotransmitters, such as GABA. They're more associated with slowdown, keeping the brain cool at a constant size. Now, for athletes that has to focus under pressure, it is crucial to have a good balance between excitation and inhibition, because imbalances can be the difference between hitting the target or hitting the floor. Now, the neurotransmitter I'll be investigating is GABA. GABA, gamma-aminobutyric acid, is the primary inhibitor of the brain. It doesn't just calm the brain down, it actually refines it. So GABA dampens distractions, it sharpens motor skills, as well as preserving composure under pressure. But here is the fascinating part. GABA might be trainable. If so, elite athletes could enhance their network through intensive training. This means that they're not just physically fit, but neurochemically optimized to perform well under pressure. Now, during stressful situations, such as hitting the last football goal or even hitting the last shot in goal, you can see here that neurotransmitters flood the brain. This can be helpful, but too much can cause overthinking, muscle stiffness, or just full-on jerky. GABA then steps in to reduce neural noises, sharper motor control, as well as preserving composure under pressure. Now, it is very crucial to understand that there are no specific amount of GABA, but each different sport may have a specific amount that is specific to their sport. For example, precision-based athletes such as gymnasts will have higher baseline GABA levels for more precise movements. On the other hand, reactive-based sports will have lower baseline levels for more explosive muscle movements. Therefore, it's not about having more or less GABA, but the amount of GABA that fits the sporting demands of that specific sport. So the central question is, what separates athletes from the rest of us? Because sure, they train their bodies just as we do, but what goes on in their brain is actually their origin. When I refer to elite athletes, I'll be referring to athletes that do their job as a profession, or their sports as a profession. So what if training actually rewires the brain? And through training, the inhibitory systems, we can enhance the GABA networks in every day. Athletes will do like that. Intensive training strengthen these GABA-urgent networks, leading to greater neural efficiency, better motor control, as well as better performance under pressure. So before I go into my specific aims, I wanted to show you the various tools I'll be using to measure brain activity, behavioral performance, as well as the chemistry behind that. For specific aim 1, I'll evaluate how intensive training rewires the brain. This will be done in the motor cortex that is more associated with muscle movement and the prefrontal cortex that is more associated with precise movement. I hypothesize that elite athletes will show distinct functions of GABA profiles specific to their sporting demands. So the participants will include 40 elite athletes that consists of 20 precision athletes and 20 reactive athletes. And then control group would be the non-athletes. They'll undergo pre-training where MRX would be used to measure baseline GABA levels, and EEG would be used to measure the brain activity. They'll then go on for 6 to 8 weeks for training in the various sports, where after they'll come back and MRS and EEG will then be used to measure the brain activity they get. As you can see here, I expect to see a decrease in motor cortex GABA levels and an increase in decision-making speed. But this will be only for reactive-based sports. Precision-based sports will show the exact opposite. Therefore, there is no specific amount of GABA that is crucial for every athlete. It's about having more or less, depending on the scores he develops.
Gotcha.
So my expected outcome, MRNS will show changes in GABA levels, where precision-based athletes will have a higher GABA baseline level, and reactive-based athletes will show higher levels of reactivation. FMRI will show better effective activation in the brain areas. Therefore, the brain can do more with less effort. For specific aims, I'll see how I can modulate GABA to boost performance in these athletes even better. I'll be using TMS, that is transcranial magnetic stimuli, that is a magnetic stimulus that stimulates the brain in a non-invasive way. This could lead to performance improvements such as faster reactive times, better motor precision, and as well as leisurely focus on depression. The athletes will be the same. I used in specific N1. They'll also undergo pre-training where baseline GABA levels will be measured, but they don't want to spit out burst stimulations. They'll have 4 sessions over a period of 2 weeks, whereafter they'll come back. MRS and behavioral tasks will be assessed again.
Great.
Here I expect to see that TMS will modulate the GABA-ergic activity in various ways. EEG and behavioral tasks will show better and clearer responses, therefore less effort, fewer errors. It is the important thing to note is that TMS will differ based on the scores in the mass. With some scores that will need a more balanced TMS, while the others need a higher splurge. So why is the study important? If we understand GABA's role performance, we can do more than just making athletes faster. We can actually rewire and transform their brain in a way that's perfect to their sport. This will also give us insight into more smarter sport training programs that is tailored to the athlete, neurotraining tools to enhance their focus and control, and even clinical applications. Because the same neural pathways that GABA uses to reduce stress in athletes could be used to care for anxiety, ADHD, as well as motor disorders. Therefore, it's not just about increasing the speed of athletes, but optimizing their brain-body composure. For future studies, I would like to check GABA over longer periods of time. For example, through an entire season to see what effect this training would have on the energy systems of the Testing interventions such as neurofeedback or mindfulness could be used to measure and see if GABA levels can be trained, such as we train muscles in our body. I would also like to compare this over various different sports, such as team, individual, as well as mixed demand sports, with the ultimate goal of developing a near performance toolkit that is optimized for the athlete and the sport they're in. So GABA might be the next unsung hero of training performance. It's important to notice that the brain isn't just along for the ride, it is steering the ship. With optimized GABA levels, we can think faster, react better, as well as staying composed under pressure. Most of us think sports are mental, but my research shows it's neurochemical as well. And if this is possible, the secret to gold medals might not be buried in muscle, but in memory. So I would like to thank God, my family, and friends for supporting me, as well as Dr. Nukanki, Dr. Hudson, and Dr. Abram for all this work. Here is my references. Over cheese.
Right. Can you just don't you sort of cut through the section and at the first day, right? Well, only then two different things. Then I got one.
Then first, I will see how training, the effect of training on the brain to make a good system. And then on the second specific, I will use CNHS.
Oh, thank you.
Are there other neurotransmitters other than GABA that would play a role here as well?
Yes, mixamine. That is actually the exciting sort of neurons that will like that is very excitation.
What would you expect to happen if an athlete took excess GABA, like a pill form? How would that play a role?
Too much can cause like increase inhibition so much that they'll become jittery and then too much shakes down the crystal and
You mentioned that this could improve care for anxiety, ADHD. How does that look like that?
I actually have big. This is just what I just learned at the same part. Like that, Galway needs to read that as well. So it has that size words.
I want to hear research that you find any like other exemplar pills of this, like in your studies, mice or other animals that show exactly how the effects are against like allocation with your or some getting the highest.
No, so CMAs will actually be one of the person
It's got you bar. Voters. Maybe.
the question. It's formality. Okay, great job.
Watch these. Switching apps to this apple. It's going to chop up money here. We filed with concentration in meds on this from Chattanooga, Tennessee, and tested it just week before years. She that required SEU with volleyball and it's softball, which she also like playing musician. And after graduation, I'm thinking gap year work is cystic or getting ready to got PH soul. When she'll get it on the ball, we have more sports stuff. Put your sports. And then so as I'm a sport said, my name's Jeff Cunningham. I'm a dual sport athlete here at all videos. And I'll be presenting Capstone calling Bill's on left back as a limited technique for shin splints. So you may be asking what exactly are shin splints? Shin splints are a bone overuse injury. They're exercise induced and they pain along the lower leg. This red area here is where pain is typically found instead of complaint of shin pain. This is a result of excessive force and pressure due to exercising too often and too much. When there's excessive force placed on the tibia, there is micro damages that occur within the bone. Specific cells called osteoclasts come in and remove damaged bone, and osteoblasts come in and repair this bone. The issue with this bone is that when the rate of loading forces exceed the rate of bone reformation, the inflammation occurs in the periosteum, which is the outer lining of the bone, causing inflammation and pain in the shin. So the significance of that study. According to a couple studies from the National Institute of Health, 60% of all liver injuries in running athletes are shin splints. Shin splints are the third most common overuse injury, following patella tendonitis and shoulder impingement. I know from personal experience, sitting out of your sport due to an injury that should have been prevented is not super fun. Mental health issues are at an all-time high, and athletes right now and getting injured only heightens this. Women are more likely to develop shin splints over men, and this is because of natural imbalances, hormone imbalances, white pelvitis, and also natural nutrient deficiencies like vitamin D and calcium. Both of these factors are very crucial in bone modeling and bone modeling.
And then the gap in knowledge that I'm going to be investigating is with wearable technology, which I'm going to talk about in a second. Delayed feedback is really the only thing that is accessible right now. So I'm going to be introducing real-time feedback as a technique of preventing injuries. So some known causes of shin splints are excessive volume of training, immense impact of force, incorrect foot training pattern, poor footwork resistance, repetitive stress induced movements like round jump dancing, and inadequate rest and recovery. So as you can see, there are a multitude of causes of shin splints, making it a little bit difficult to completely prevent shin splints because you can't focus on all of these at one time. So a primary aim of my study is to find which one of these causes is most important and how we can target that one to prevent shin splints best. So some current therapies are, as I said earlier, rest is typically the most suggested therapy, but as an athlete, I know in the slow and the high demand of season, resting is suggested 2 to 4 weeks to decrease inflammation, or even the 3 to 6 months to full heal is not super realistic or very feasible. So other technologies for therapy are considering icing and regular stretching, utilizing some arch support or orthotics, which kind of regulate muscle imbalance and prevent overpronation of the foot, which is the internal rotation of the foot. Prioritizing flexibility and specialized strength training, taking non-steroidal anti-inflammatory drugs on the regular to decrease pain and inflammation, and to perform cross-training exercises as a mode of recovery while still being in fitness for your sport. This can be cycling or swimming or once instead of in things fun. So this right here is an X-ray. The side on the left is the anterior posterior view of an X-ray, and the one on the right is the lateral view. The thicker bone of these two is the tibia, the smaller one is the fibula. So the tibia is the primary concern of shin splints, and these red arrows here both show a little bit of a protrusion on the tibia, which is the inflammation in the periosteum, which I talked about earlier, which would be diagnosed as shin splints and complaining of shin pain. So my research question is, can real-time biofeedback from wearable sensors actively modify an athlete's movement patterns to prevent overuse injuries, specifically medium tibial stress syndrome? So what exactly are wearable sensors? Wearable sensors are electronic devices designed to wear on the body to track, analyze, and to transmit personal data. I'm sure some of you guys are pretty aware and knowledgeable about Apple Watches or Fitbits, but some new technology like smart glasses or smart insoles. Smart insoles are very important in a second. A lot of upper level elite athletes and programs are utilizing these to track training volume, to investigate better training patterns, and hopefully even prevent injury in the future. So that's my question. Can real-time biofeedback from wearable sensors actively modify athletes' movement patterns to prevent shin splints? So for my study, I'm going to be conducting a 2-phase methodology. The first phase is going to be observational in nature, and the second one will be more interventional. For my participants in my study, I'm going to be taking 100 female collegiate athletes, 25 of which have never reported any shin pain before, 75 of which either have had shin splints in the past or are at risk of shin splints as they're taking their exams to be up. They're going to be in endurance-based and high-force sports, specifically running. In my case, it's going to be track and cross-country. My inclusion criteria include either a portion of my participants with no restrictions splints, as well as shin splints are at risk. My exclusion criteria is going to be males, people that have had previous surgeries or previous lower limb injuries, and any conditions affecting their gait, which is just their normal walking cycle.
Sure.
So for my first aim in my first phase of my study, it is going to be to characterize and investigate biomechanical and training load markers that correlate with medial tibial stress syndrome. My hypothesis is that athletes who are more likely to develop this condition will have elevated levels of specific biomechanical and training load markers in comparison to those who are not as likely to develop it. So my groups, for group 1, I'll have 25 females at high risk, and my second group will be 25 females at low risk. So you may be wondering, how am I going to figure out who is at high risk and who's at low risk? I'm going to be conducting 2 separate tests. The first test is going to be an individual drop test, which is a test that assesses foot pronation. Foot pronation is a protective mechanism that is to monitor for regulation and absorption of shock. So in the first picture here on the left, labeled A, it is a picture of a patient I'm going to have them sitting down in a non-weight-bearing position. This black dot here is going to be placed on the navicular tuberosity of the foot. the distance between the ground and that dot is going to be measured and mark the line as a baseline. And then in the right picture in B, you can see I will ask the patient to stand up on both feet in a weight bearing position, which will be standing, and I'll do the same thing, measure from the ground to that same dot. And if the distance between these two lines are above 10 millimeters, that is considered a positive ventricular drop test, which also leads to and indicates excessive foot pronation, which is inward rotation of the foot and running, standing, and weight bearing exercises. And that increases rates of shin splints, which would constitute as high risk. And then the second test I'll be doing is a longitudinal arch angle test. I will keep the dot on the navicular tuberosity. I will add a dot on the medial palliatus, as well as the first metatarsal head, and then I will see what angle this is. A normal arch angle is between 150 and 170 degrees. A high arch is considered there is an LAA less than 150 degrees, and a flat feet are constituted with them as a degree greater than 170. Flat feet as well as extra arch feet are both at high risk for medial tibial stress syndrome due to improper muscle balances and gait bearing. So my data collection, I'm going to be looking at tibial acceleration, ground action forces, foot strength and guidance, step length, cadence, and joint angles. I'll be using attachable IMUs, which are inertial measurement units, force plates, and high-speed video to do this. I'll also be looking into weekly running volume and intensity of the training, different running surfaces and how that affects it, and overall step count as well. So what I'm expecting to see is I'm going to be able to identify which key biomechanical and workflow markers are important and associated with shin splints. I'm hopefully going to discover a threshold of a specific number of which one of these biomechanical markers is excessive and which one is low, specifically tibial acceleration and ground reaction forcing. And then hopefully I will be able to put a relative weighting of which one is most important. Like I said earlier, there's way too many causes of shin splints. So figuring out which one contributes the most to target down in the future. So for my second aim, this is my interventional part. It is going to be to evaluate the effectiveness of real-time biofeedback and modifying the movement patterns and reducing risk of shin splints. For my hypothesis, it is to see key biomechanical risk factors associated with shin splints are going to be significantly reduced following the implementation of real-time biofeedback updates. So for my groups, both of these groups are going to consist of 25 females at high risk for shin splints, except for my first group, maybe my control group, receiving no biofeedback, and my second group will be wearing smart insoles in their shoes, and they will be receiving real-time auditory and haptic feedback. Their auditory feedback is going to be a beep when their tibial acceleration is outside the limits of a regular, and then their haptic one is going to be vibrations when their foot striker pattern is extra heel devoted or extra toe devoted. You want to be a mid foot striker. So for my timeline, there's going to be 4 training sessions per week. 60-minute sessions each one. Obviously, it's going to be running pace because that's what I'm looking into. And then I'm going to be monitoring their progress over a 6-week span. For my data collection, like I said earlier, group 1 is going to be equipped with regular insoles. That's going to be the single group. And then group 2 is going to be equipped with wearable technology, smart insoles. Okay. Also, key to note, my athletes are going to address any severe shin pain before and after every single training session, so I can compare its results later. So I'm expecting to see my second aim. I'm going to expect to see improved biomechanical patterns, tibial acceleration that has decreased, and improved in the foot striking pattern and lessening ground reaction forces. Secondly, I'm looking to see reduced factors of shin splints. There's going to be a notable increase in angle at foot mobility, lessen weight bearing imbalance, and increase step rates. And finally, I'm looking to see, even after I track these athletes for 6 weeks and I take away my biofeedback, this muscle memory has formed and corrections in their biomechanics of running should have been corrected a little bit, and it will maintain even after I take away biofeedback. So to analyze the data, there's going to be 4 different ways to do this. The first one is going to be a correlation between the biomechanical training load with the severity of shin splints. The second one is I'm going to mean and static conviction from these biomechanical training load markers in group 1 and group 2. And then I'm going to compare the differences between these markers of high risk and low risk and see which ones are high, which ones are low. And then a logistic regressive model will predict which predictors are the most important in developing shin splints.
So for my future studies, I would love to expand on this study, following the progress of these athletes over a longer period of time, even for a whole entire season, or maybe even a year or two to see how to see the difference. I would love to expand the study for male athletes and then compare between male athletes and female athletes. I would love to include other high force and high impact sports, volleyball, basketball, soccer, football, anything like that, where you change direction a lot and you're doing a lot of running. Investigating the effectiveness of real-time biofeedback at different levels and divisions of competition. So maybe extending this to middle schoolers or high school athletes or even Olympic athletes and seeing the range of competition if that has any effect on the training leading to displays. And then I would love to look into the physiological and behavioral impact of athletes following this real-time biofeedback. I'd like to acknowledge God for bringing me here, all my professors for all of your patience and your hard work with me, and then all of my friends and family, my teammates and coaches. I would be writing or have successful with IRS. Here are the references.
Yes.
That's all. The chapel?
Chadwick, does the person's weight have any correlation to shin splints?
Yes, it does. Body mass index is something that I sort of looked into, but not super in depth. I know that I talked a lot about ground reaction forces, and a typical ground reaction force just when walking, it is how much you weigh. But when you're running, it can be elevated to 2 or 3 times your body weight. So when your body weight is excessive, that's getting even more stress.
Do you have a weight or BMI that you would like to consider in your studies, or no?
No, not really. I think I really just wanted to focus on females just because I'm female and I know it's very prominent. I've grown my softball team who thought she had shin splints at first, led to compartment syndrome. And so I think it's very close to my height. So I'm going to look into that.
And your college age females, is there a certain age that you'd like to look at in particular?
Yeah.
Or cut off that's
Yeah, really just all the college, like freshmen to seniors, just saying like the range, because I could also compare like the extent of training, because also when you're a freshman, you're going to come in and not have a ton of like college experience training. So that'd be cool to compare freshman year to senior year as well.
So I knew you would think I want to keep back and maybe determined place. I guess how to touch the ground, the sensors and everything. So what's the like the more on therapy that you're giving them instead like you improve the workout bias? Is it just like changing the way that they run along?
Yeah, so some like biomechanical corrections. So like I said earlier, a striking pattern, if you're super toe dominant or super heel dominant when you're running, both of these are not super suggested in running. So correcting through biofeedback, my captive. So I'm correcting yes, and like foot stride, knee, so like that.
Just a fun fact, last time I read an article on this, which is really wild, and they have a shoe that was designed to kind of collect data. Except the shoe had button battery, and the button battery burns it doesn't eat the patients as they had distance running. So, should this progress into something? This one is a button battery. Wow.
That's it. That was very time. Great job, Hopkins.
Okay, I'd like to introduce the next speaker, Timothy Davis. Tim's majoring in biology with a concentration in medical sciences with a minor in chemistry. He was from Fredonia, New York, and has been at SDU for 4 years. While at SDU, he's served as the CNHS TA, SMTA Vice President, AIDS Vice President, PHSO President, Scientific Mentor, Manager, Health Services Volunteer, Volunteer Coordinator, participated in both organic and neuroscience research, served on a medical mission trip to Uganda. After graduation, he plans to attend Cedarville University in May to obtain his master's in physician servings. That'd be for the door to.
Congrats on the production. Once again, why everyone, my name is Timothy Davis. I'm so excited to talk to you all today. So you think of plants, if you see a plant, it's gonna grow. For me, if I see a plant, it's probably gonna die. So you see a plant, it'll grow, hopefully. You need a child, it'll grow. And the same when it comes to cancer, basically feeding cancer directly through energy going to it. So modestly looked at is cutting cancer's fuel line directly through dual lactate dehydrogenase and monocarboxylate transport inhibition. So we look around the world's cancer statistics. Currently, every year there's about 20 million new cancer cases that are diagnosed every year. That's roughly 40.5% of the population, or 1 in 4 people that are going to be diagnosed with cancer. This equates to about 9.7 million deaths every year associated with cancer itself. It's obviously the second major cause of death. It's a major target for only today. When we look at U.S. alone, currently the U.S. spends $208.9 billion on cancer treatment, expected to grow every year to improving in technological advancements. Current states such as New York, Pennsylvania, Michigan, Pennsylvania, Louisiana, and Florida have the highest diagnosis rate of cancer. And we look at the difference between men and female, men are more likely to be diagnosed with cancer itself. And we look at the U.S. and the world alone, the top 5 cancers include lung cancer, breast cancer, colorectal cancer, prostate, and melanoma. And for my study in particular, we're looking at breast cancer instead. So according to the World Health Organization, the American Cancer Society and the Center for Disease Control have varying different definitions of what cancer is. So kind of give you a basic definition of what cancer is. It's a disease in which abnormal cells divide out of control and invade other tissues. So typically it's often occurs with symptoms first appearing. Oftentimes these symptoms aren't directly caused associated with cancer itself, they're indirectly. So cancer itself is altering the environment in which the president being thought of those symptoms come up to. From Medicare-specific diagnosis, typically cancers are diagnosed on a 1 to 4 stage. So 1 would be the most localized form, or 4 is indicated that has a cast up. It's moved from 1 or 8 to a different order, and ultimately the most challenging spirit treat. From there, you get treatment options, as we'll discuss later on. Those treatment options will be implemented, and then from there, either you destroy cancer, go into remission, or an alteration of the cancer treatment itself. So we look into the varying cancer treatments itself. We have very different options. So hormonal therapy, we have surgery, we have potential bone marrow transplant, we have immunotherapy, radiation therapy, and obviously the most common one is chemotherapy. Oftentimes these are most in tandem as combinations of more effective approach in treating cancer, often seen as a more aggressive combination. So you see radiation and chemotherapy put together. But for my study, we're going to look at chemotherapy into 2 different kind of chemotherapeutic drugs itself. So if we look at cancer itself, there's varying different characteristics and features when it comes to cancers and how they operate in the body itself. So a couple I include there. Sustained proliferating signal, evading growth suppressors, immortality, often called as they're going to replicate over and over and over again, activating invasion and metastasis, inducing angiogenesis. So for you that angiogenesis is basically saying you're going to create more and more blood cells to bring more and more nutrients to the cancer cell itself. And then finally, you're going to resist cell death. However, in new research, we're coming to find out, so potentially new features of cancer for totally tap nature. One of those actually being is that cancer cells itself are avoiding the immune system. So potentially they're recruiting tumor-associated macrophages, what goes to protect the tumor itself, and ultimately affects potentially cytotoxic T cells, macrophages, which can come and destroy the cancer itself. A potential factor that's causing this to happen is an alteration in the tumor environment, the area around the tumor itself. We're seeing as a decrease in pH that's affecting the immune system itself. So one potential hypothesis or idea that's associated with all of this in general is what comes down to the major hallmark that's coming to a new light, which is dysregulated cellular physics we're going to look at today. So cellular respiration is how your cells itself make energy where it operates and functions. There are 2 different pathways. So we have an aerobic and an anaerobic. So aerobic is occurred over oxygen conditions, and anaerobic is occurred over or a lack of oxygen. So we follow these blue arrows to give you an idea of what aerobic respiration looks like. This glucose itself is going to enter the cell. It's going to go through this process called glycolysis. It is converted to pyruvate. Pyruvate is going to enter the mitochondria, which I'm sure many of you heard of as the powerhouse of the cell. So from there, we're going to enter the citric acid cycle, and then let's go to electron translation. We're going to produce ATP. ATP is what drives many of our functions of our cell. This is the energy currency of our cell itself. But you can see that there's multiple production of ATP. However, in the lack of oxygen, cells itself begin this anaerobic respiration process, as seen through these greenhouses. So staying kind of in our passions, we're going to go through glucose, go through glycolysis, and then from pyruvate, we're not going to enter the mitochondria. We're going to go through lactic acid production and produce lactate outside the cell. So what if cells itself are hijacking the system and making it beneficial for themselves? This has become seen as the Warburg effect. The Warburg was discovered by Otto Warburg in 1963. And seen now as a hallmark of cancer itself. You've seen what's important about this or different in cells compared to cancer cells is that it's going through anaerobic glycolysis. So as you see, anaerobic condition, we're typically going from glucose to pyruvate and eventually to lactate in the absence of oxygen. However, cancer cells itself are doing this process in the presence of oxygen. It's able to do that cycle over and over and over again. So from there, we're seeing an increase in glucose uptake. So from these cancer cells drawing in glucose to convert it to lactate, glucose is going to go from high concentration to low concentration. So it's in whole glucose more inside the cell. So typically normal cells are from 17 to 14% glucose uptake. You see a massive increase of 60 up to 70% uptake in glucose itself. From there, you're going to have this molecule called NAT activated. So if you look here at the convergence of pyruvate to lactate, NAT is going to come in and get oxidized and get converted to NAT plus. From there, typically, NADH goes into the mitochondria and sees what we saw in the last slide, the electron transport chain, which reduces the ATP. But from there, the NADH is being recycled into NADH and is not able to go into the mitochondria to complete ATP production. From there, since we're going to have this buildup of lactate in the cell, we've got to get rid of it somehow. Typically, cancer cells will pump this lactate out of the natural cellular environment. From there, it's going to lower the pH of the microtumor environment, making it acidic. And from there, as I talked about earlier, due to the decrease in pH, you're going to have immunosuppression happen. It's affect your cytotoxic T cells, your T regulatory cells, and your macrophages itself. So when we look at everything together, what do you think is the main culprit? And what I found there is what if we can target lactate itself? So currently, when you look at lactate, here's the molecule of lactate, and according back to that pathway here, there's two main proteins I want to draw your attention to. The first being lactate dehydrogenase A. So lactate dehydrogenase A is going to convert that pyruvate into lactate itself. And our second is going to be microbiota transport. That's going to shuttle lactate from the intracellular environment over into the extracellular environment. Once again, we get that expression and that decrease in pH. So what if there's a way that we can block both of these proteins and how it's that gamma treatment? So currently, there are two different types of medications. Aloximate itself is still in clinical trials. It's not moving yet to humans. It's more focused in mouse models. However, serosafety has been in human because you have to use this anti-hypertension drug in some. So aloximate is an lactate dehydrogenase A inhibitor, and serosafety is an monocarboxylate inhibitor. So what's great about these drugs, they have very similar properties. They have anti-cancer effects. They're going to dysregulate the metabolic function because they're going to block lactate and the production of lactate, which will hopefully remodel the microtumor environment and lead to immune enhancement. So what if we combine what aloximate and serosafety as a more aggressive approach to cancer treatment to reduce cancer size and modulate immune system? That's exactly what I'm saying. So there are two different parts. So the first part of my experiment is to evaluate the synergistic or the combination beneficial effects of aloximate and serosafety on cancer cell viability, proliferation, and apoptosis and in vitro model. So my hypothesis is that there will be decreased cell viability, proliferation with increased induction of apoptosis as compared to a normal breast cell. So it comes to study using three different cell lines. My first one could be NDCA NMD231, also is a triple negative breast cancer. So these type of cancers lack receptors for estrogen, progesterone, and HER2. These type of cancers are more aggressive, and there's very limited therapeutic options for these. My second will be SKPR3 or HER2 positive. So it does lack estrogen and progesterone receptors, but it does have that HER2 positive receptor. And these types of cells often there's more therapeutic options to treat cancer the cell. And then lastly, using a normal breast epithelium, notice an MCS, and you compare what scan cells look like under these conditions compared to cancer cells itself. For my control experimental groups, my control group will just be receiving D-methyl. This is the vehicle once the drug is dissolved. So you're going to receive L-love, or else you're going to receive just aloximate alone, serosafety alone, and you're going to receive a combination of just aloximate and serosafety together. For aloximate alone, they will receive increased different doses you can get. We'll be starting at a 30 millimolar concentration, and serosafety will be at a 1 micromolar concentration, and then for the concentration, we insult these individually and play them together using So we have to look at its study cell viability, proliferation, and apoptosis. What would happen is we're going to measure the drugs to cell lines themselves. We're going to measure them every 24 hours for early and late response for a total of 72 hours. From there, we run 2 different tests to check for cell viability and apoptosis. So my first one's going to be an ATP assay, and my second one's going to be a Western blot. So by doing the ATP assay, it's going to check for ATP concentration. Since cells need ATP for continued cell viability, if they have a decrease in ATP concentration, which is that the viability is decreased, and their demands and their functions have decreased as well. So we hope to find is we've done these and staying on through slide is a decrease based on the green dots that pop on the screen. Referring to us, there's a decreased ATP concentration. I know we run our Western blot, we're going to check for apoptotic markers. These are markers that are often associated with cell death or cell growth. So we want our Western blot, we're going to find these concentrations or bands, hoping to find high amounts of apoptotic markers. So expected results from this is we look at both my cell cancer lines. We're going to hopefully find a reduction in the ATP concentration. So we're not going to find many green dots on our screen. We're also going to find an increase in VAX. VAX is a pro-apoptotic marker. We're going to find big, strong band on our Western blot. And from there, we can further leave a decrease in cell viability, proliferation, and hopefully an introduction into apoptosis. And then we look at and compare that to our normal breast epithelium. We're going to find a steady state of ATP concentration as these cells themselves will be going through regular cellular respiration through normal mitochondrial functions. And they also be equal in absence of VAX, which is a pro-apoptotic marker, and BCL2, which is an anti-pro-apoptotic marker. Always kind of inferring to us that these cells remain steady of operating at physiological functions. This moves me into my second part of my experiments. My second part will be looking at determining the impact of tool inhibition on tumor-like metabolism and the immune microenvironment during an in vivo study. So my hypothesis being that may decrease tumor growth in correlation to altered cell metabolism and tumor microenvironment and linked to immune enhancement. So we're using 2 different mice models. My first mice model is going to look at lactate metabolism itself. This is going to be an NT-231 xenograft model. So what's great about this model is that it lacks receptors for B cells, T cells, and cytokines. So we can look at just specifically how these drugs affect lactate metabolism itself without the alteration of the immune function. My second one is going to look at immunosuppression, which is all C mice with 4T1. So 4T1 just means it corrects cancer itself. It's injected to all C mice. All C mice are great for analyzing immune function itself. Very similar control and experimental groups. We have our control group, oloxamine alone, serostinamide alone, a combination of the drug itself. The only alteration being the amount of drug that we administer, since these are a larger specimen that we're dealing with. And then when it comes to measuring lactate health and immune profiling, when it comes to measuring lactate health through our gene drop model, we're going to administer the drug every 2 days. And we're going to image the mouses every 2 to 3 days for a total of 46 days. This allows us to analyze over long term, and we're going to analyze them through biomimesis. And then we look at our biopsy mice to look at immune profiling, saying whenever we're going to administer the drug every 2 days. However, we're going to image them every 7 to 10 days, still for a total of 40 to 60 days. And this is using flows to comments. So we're looking at lactate metabolism. This is kind of the idea of what bioluminescent looks like. So these hot and red concentrations are where there's rapid growth, high concentration of tumor cells, lactate metabolism, and there's blue areas for more decreased concentration. So hopefully to find the correlation over 40, 60 days is a decrease in these high red concentrations and more shift to these blue, and a decrease in the size of them themselves. So hopefully it brings us that there's a reduction in tumor size and eventually an altered tumor microenvironment. And as we look at immune profiling, this is kind of like if we use cytotoxic or our flow cytometry looking at our cytotoxic T cells. Once again, our red area is high concentration and our blue area is more decreasing concentration. And it's based on the presence or location of these dots referred to as the type of cells that are present. So we hope to find is an increase of our red prevalence where T cells and B cells will be located. And brain interest is a high increase in immune functioning, so there is enhanced immune function and a reduction in tumor size since these immune cells themselves are functioning. What I hope to look at in the future is to do a lactate assay to measure the potential lactate concentrations. Because since our immunity in these molecules, what is finding and that if there is a reduction of lactate anywhere else happening, that we can inhibit those as well. Doing an NXMV diet, so this is going to turn early or late apoptosis. So these drugs had an early effect or a later effect on cancer cells themselves. And lastly, with a liquid biopsy or your base to your standard blood draw, so look at immunosuppression markers as see how these drugs are altering microenvironment to the tumor itself. I'd like to acknowledge God's allowing me to continue to study amazing creation every single day to learn more and more and more. My professors challenge me and push me harder to do better and to work harder. My friends and family for continued support, people lead now, push me and encourage it. Here are my references. And if you have any questions, I love it. Thank you. Yes.
Tim, if glucose is what's ultimately feeding the system, right, and feeding the cancer cells, could you elaborate on the role of a diet high in added sugars in the proliferation of cancer cells?
Yes. So cancer cells, they're going to draw that glucose into them. So they're going to starve regular cells. So what we're hoping is if we can decrease kind of the glucose that's being converted, that glucose is up about regular cells and reduce kind of the tumor size itself. Is it good? What's your
Kind of, but like if there's a diet that has an additional increase in added sugars, like eating way too much, processed sugar,
Yeah.
how would that affect the cancer? And would a reduction in dietary sugar in combination with your drugs, would that potentially be more synergistic?
I think in general, a high sugar diet is probably non-favorable because you're going to have other effects later on in life compared to just cancer itself. So just advise against that. But when it comes to looking at these models and glucose and you kind of increase in glucose itself, potentially see these cells are going to increase more and more just because they're taking more and more glucose because there's more glucose prevalent into the blood side, the blood supply itself. So you take more and more in. But hopefully, since this approach being more dynamic or more aggressive, it can decrease the tumor size before it has grown to a more proliferative or unstable lethal state before it has later effects like anything. To make those tests.
I think it'd be cool for a future study to look at baseline serum glucose levels in like the 20s of everybody before you get into those high, fasting blood sugars and see if there's correlation between, patients who are fasting in the 90s and that's just their standard. So they don't have diagnostic disease yet, but if they have more bioavailability of that, it may be, a predictor.
Yeah, I'll put them some markers and indications. Yeah, that's the fun.
So about the good
Keep breaking. That's any questions?
It's great job. We're going to move on 7. It's the big red fight again. Period on the door. I'm out for the alumni and we're up.
Thank you.
Kind of people work.
They do. They cite the show.